Good afternoon, ladies and gentlemen. I'm here sharing with you a presentation on trends and challenges in management of osteoporosis. Osteoporosis is no more a silent disease. It's a bone-shattering thunderstorm. We in India are facing it and trying our level best to push it behind as we age. Aging should always be graceful. We all hope and pray that our parents are comfortable, and when we are their age, we should also be as comfortable as we can make them. We should believe in adding life to years rather than adding years to life. Unfortunately, in this aged population, one trivial fall may change the equation. It's extremely common to get a spinal fracture, most commonly at the thoracolumbar junction. A closer look on an X-ray would confirm that the vertebral body is collapsed and shortened to a certain extent. What do we do next? There is a lot of planning and introspection both from the family, the patient, and the treating doctor. Often such people are not brought immediately. They have been started on pain medication, some have been given a brace, some have been advised bed rest, some have been told walk around within limits of pain. But investigations only begin when a visit to a physician is made. X-rays may need to be done. We may need to do CT scans or MRIs, check a vitamin deficiency, do a bone density, a DEXA scan, and certain other tests to rule out if there is any cancer or malignancy. Please remember that as we age, if we have a fracture in the spine, we need a prompt diagnosis and optimal treatment for preserving skeletal health. It is interesting to know that if we were to look at people surviving beyond 50 years of age, 50% of all women, 1 in 2, and 25% of all men, 1 in 4, will suffer with a fracture in their remaining lifetime. Once you have one fracture, there is a 2 to 5-fold possibility that you will have a second fracture, osteoporotic in nature. Yet, very few of such patients get evaluated for the basic cause, which is osteoporosis, and ignorance is practiced with these fragility fractures. It is important that we, as treating physicians, realize the gravity of the situation. Often this fragility fracture first comes to an orthopedic surgeon and may be the first sign or telltale of osteoporosis. We orthopedic surgeons, spine surgeons, primary healthcare physicians are actually the first contact for this dreaded no more silent disease. There has been a huge study. 90% of patients over various countries, not just ours, do not routinely get a bone density check after first fracture. 75% of patients are unaware of an entity called osteoporosis. Very unfortunate, because such people will continue to have pain. As they grow older, their height would get shortened, they would start stooping forwards, their self-image would diminish, and they would have an extremely poor quality of life, besides having huge possibility of yet another fracture. Truthfully, they are knocking on the doors of death. Mortality is called earlier. What is osteoporosis? It's a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of the bone tissue, leading to enhanced bone fragility and hence an increase in fracture risk. This is what WHO called it. How do we assess the bone density? Earlier we just had x-rays. We used to look at x-rays and say, oh, this looks like osteopenia, quality of the bone looks thinning of the bones. Today we have much more. We use a tool called DXA, bone mineral density. This gives us an idea by a non-invasive modality like an imaging as to how bad is the quality of bone on that individual as compared to people of the same weight, same age, and same sex. Hence, we have a T-score, a score which tells us that our bone quality is normal, a score that tells us that we are weaker between -1 to -2.5 of standard deviation, or that we are osteoporotic, which means between -2.5 and anything lower than that. Severe osteoporosis is this situation plus a fracture which may at times just be what has caused us to diagnose it in the first place. Let's go back to the fracture. Old man stooped forward, quality of life diminished. Or a lady who had a fall just incidentally, a trivial fall. Normally a fracture would not occur had she had this fall a few years earlier. In these situations, what do we need to do? We need to look at the family history of osteoporosis. Did that lady's mother or grandmother have similar history? Look at the menopausal state. Look at the basic nutrition. Was she taking steroids or some medication for epilepsy, seizures? Has she been a very good athletic person all her life, or has she been a couch potato? Has she had multiple fractures in the past? Does she smoke, consume alcohol? Are there any other diseases which make her more prone to a fracture? Well, all these should be evaluated. Plus, you need to check if they have lost height in the last few years. Is it that they are losing weight? Is it that the quality of their life has diminished? Are they getting depressed by all this? Various tests need to be done, and we do all of them to rule out if it's just benign osteoporosis, or is there a disease which is hidden within, something like a malignancy which may get unmasked, a myeloma, a secondary, a metastasis from a cancer. All these need to be looked for and ruled out. Is this disease treatable? Is there a way of improving your quality of life? Well, there is. There are interventions and medications both. Let's look at that fracture where we started. This went on for about 6 weeks. The patient continued to have pain. The X-ray showed that there was a further collapse, and it also showed that there was a fluid cleft developing within. This fluid cleft further worsened with time, but the spinal cord was still spared and there was no neurological manifestation. Such a patient in agony in 2005 was subjected to a minimally invasive procedure, a procedure where a small needle was put under local anesthesia within the vertebral body. This was then confirmed by imaging, taking 2 views from the front and the side, and having taken a biopsy to rule out if there is any disease that is hidden, we put in bone cement. A normal cement used in joint replacements throws a lot of heat. This cement is a low heat producing, low exothermic cement which is put in to make this weak bone stronger from the front right up to the middle, but avoiding the rear part where there is close proximity to the spinal cord or the neural structures. These images confirm that through one small hole, that weak vertebral body has been filled with bone cement, polymethyl methacrylate. Images post-operatively confirm the same, and patient has significant pain relief almost immediately. I was doing this from 2005 to 2009 when suddenly this huge New England Journal of Medicine, respected by all of us, came up with trials challenging the efficacy of this procedure. There was a lot written in this journal, and this particular procedure was probably going into slight disrepute. It was not sure whether this was a mechanical stabilization of the fracture by the bone cement. Was it that the bone was being heated and necrosed so that the pain disappears? Or was it a chemical reaction by which the nerve endings were getting desensitized? Whatever it was working. But people said it was being overdone. It should be restricted to people coming around the 6-week stage alone. There were so many people speaking for and against this procedure. And as I look at anything in literature, statistically, we have to here go with experience plus evidence. Evidence was probably working against the procedure, but experience in very specific patients, maybe just 4 or 5 in the whole year. If I see about 50 to 60 in a year, 4 or 5 such patients deserved vertebroplasty or cement augmentation. And this is where I stand today with this procedure. There are certain situations where things may not get treated with just a vertebroplasty. Let's look at this lady. She had everything wrong with her, from diabetes to blood pressure to an irritable bowel syndrome for which she was taking steroids, had a trivial fall. She was not taking any treatment for osteoporosis. Her bone had started collapsing. Can you see that there? At 6 weeks, this was the collapse. At 12 weeks, the collapse had further progressed. And at the end of 3 months, that's how bad it had become. And that cleft was also visible. That means that there was something going wrong. Medical treatment for osteoporosis was initiated at this stage, but pain persisted. Pain whenever she turned in bed was unbearable. The CT scan unmasked this huge cavity or a gap that we see there. This was confirmed, and there was also pressure developing on the spinal cord, the theca, which was there at the L1 level. It was reconfirmed with an MRI, and it was now responsible for her symptoms. She was losing control over her bladder and bowels. She was passing inadvertently urine and motions in bed. Bedridden. She was continued with nursing care for 1.5 years. This lady was in agony. Should we now just do bone density, vitamins, check her, or should we look at surgery? I could not look at this lady in agony. I had to now take a decision. Would I just put in cement? Would I need to remove the pressure from the theca and remove the pressure on the spinal cord? Would I need to put some metallic support at the rear? Or would I need to go in from behind and front surgically? Well, I took a call and did a procedure only from the rear, where we pushed in some bone substitute into the weak bone, not bone cement, and put in 8 screws, 2 rods from the rear and supported this lady. She had significant relief, recovered neurologically, though slowly. Another lady, multiple fractures in the mid-back, which is the thoracic spine, with an old healed fracture in the lumbar spine causing pressure on the thecal elements. This lady had a combination of pain in the mid and middle of the back and some weakness with difficulty to walk short durations. She had 2 pathologies, a fresh fracture at the D10 and the L1, and an old healed fracture in the lumbar spine causing severe lumbar canal stenosis, by which the nerves in the lower back were getting compressed and she could barely take a few feet without stopping and lying down. Would we put in cement in this patient for the fractures above? Would we leave the lumbar canal stenosis at the lower down for itself to heal? Would we also do a small surgery for that? Or would we just give her medicines and wait and watch treating the osteoporosis? I thought of a combination of surgery with medicines. Put in cement at the higher vertebrae, which is D10 and L1, and did a microlumbar decompression lower down. If you notice, this was cementing using balloons on either side, 2 kyphoplasty balloons, similar to vertebroplasty, but here we can put in 2 blobs of cement in a more controlled manner, such that there is no pressure anywhere on the neural elements. There is literature available where patients come with fractures in the mid-back and lumbar canal stenosis, where both the surgeries could be done together. Have we given it a thought that we as surgeons at times suggest that we'll put in these hard, strong screws into bone which is soft like butter? It may not work. Today, when you have to use screws in bones which are weak, we augment the screws with bone cement. How do we augment? Well, in the lumbar spine, where one level is only affected and the T-score is not too bad, where there is fluid to be filled in with cement, we would do a CT guided biopsy, confirm that there is no malignancy, put in the cement in the front and a support at the rear after removing the pressure on the thecal elements. This open vertebroplasty with stabilization. But in the thoracic spine, where the T-score is minus 2.5, borderline between osteopenia and osteoporosis, and there is a delayed neurology, we would need to use structured support from the rear with augmentation and stabilization in situ. However, when there is a collapse or a kyphosis or an angular deformity coming in, just doing things in situ would be incorrect. Here, patient is also developing weakness and has a T-score of minus 3.1, which means that it's working further against the surgeon and the patient. In this situation, rather than add cement in the front, we established a stabilization by shortening the rear. This is called a pedicle shortening osteotomy. Here what happens is, rather than add cement, we reduce the posterior length at the rear such that the spinal cord is decompressed, and we do not load this implant as much we would if we were to restore the length completely. There is a lot of study today where posterior shortening procedures are being favored against a back and front procedure. Literature is also at times speaking against things we fear, like putting in cement in the presence of thecal compression. There is literature supporting the same, but we as surgeons do not recommend putting in cement when there is pressure on the thecal elements or the spinal cord. What are the challenges we face? Challenges we face: the bone is very, very poor, so the screws may not hold. The bone may crush and leave gaps or voids after a fracture reduction. How do we add strength? Screws can be coated with hydroxyapatite. Cement can be used with screws. Screws may have holes in them. Cannulated screws through which cement can be put. We can put in screws very, very carefully such that it holds the front or the upper part of the bone, the vertebrae. We may use hooks. We may use wires instead of screws or in addition to screws. Ultimately, differences in motion patterns suggested that calcium phosphate cement augmentation, a new type of cement may enhance fixation in addition to hooks and wires. Just to share a few of our patients who have been stabilized from the rear using cement with screws, using short screws at fractured levels, using other modalities at lumbar spine, doing cement augmentation of the fracture and cement augmentation above and below. In certain situations, very difficult to handle, bone stock extremely poor, go back to the conventional modality, which is putting in wires and rings which support it from the rear. Keep the ego of the surgeon aside and give them a brace or a belt to wear above this and treat the osteoporosis aggressively. When you can't impale with a screw, engulf with a wire and hold it. Of course, we have to improve the nutrition of the patient, treat all the other disorders, reduce smoking and alcoholism, and use medicines. Adequate calcium and cement and vitamin D. Add nutrition, give up smoking, give up alcohol, and use medicines which are available today. What are the medicines available? HRT, hormone replacement therapy. My gynecology colleagues really do a good job with this. Bisphosphonates. These prevent further breakdown of bone. They do not necessarily add to the quality of bone. What do? They maintain your bank account, but they do not add more to your bank account. SERMs, again used more commonly by the gynecologists. But the one which has really changed the entire situation, caused a paradigm shift, is an anabolic called teriparatide. It needs to be injected every day by the patient for 2 years. Not a very comfortable experience, but believe me, well worth it, because it really can turn around the quality of life. There are various comparisons of various drugs available which strongly suggest that teriparatide is the only drug as of today which works as an anabolic and can improve the bank account of your bone health rather than just prevent it from further deteriorating. We as orthopedic surgeons, spine surgeons, primary physicians have an opportunity and an obligation. We need to treat it as important. It's not difficult. It will be rewarding both to the patient and to us, and will soon become a standard of care. Finally, it's not a silent disease. We need to diagnose it early to give good quality and respectability to the elders in society. We are reaching there soon. Osteoporosis increases morbidity and mortality. It should be treated on par with other diseases like blood pressure, diabetes, thyroid issues, myocardial infarction, stroke. All of them need lifelong treatment. So does osteoporosis. Fracture can risk our future, and refractures are very common. Most patients do not get diagnosed or treated. Treatment is available today, so please start using it, both the patients and the treating doctors. Please remember, orthopedic surgeons are usually the first point contact, so we need to educate our colleagues and share our experiences. In India, osteoporosis differs not only from other parts of the world, but also from one state to the other, and each one needs to be looked at with a special consideration. It is our duty to empower each one of our colleagues to spread the message of treating osteoporosis in the Indian circumstances. We need to be safer as we grow older. We know that it is at times a surgical option, and both surgeons and anesthesiologists may at times shudder away from such patients. Why is that so? Because these patients have huge emotional, physical, and at times medical legal challenges. But please, all my colleagues should understand that all boats are safe in the harbor. But that's not the reason why we build ships. We have to take the risk, even if we are all alone facing a situation which is daunting. We have to take it and face each patient as he comes to us. Take the patient in our counseling family, look in the same direction, catch the bull by the horns. Osteoporosis is very dangerous, and correct it as soon as possible, because there are hordes and hordes of such patients in our country who deserve treatment. Osteoporosis needs to be wiped out sooner or later. It is something which has come, will stay, and if we can help it, will pass off. I'm sure you would all join hands with me and treat this dreadful quality of life debilitating disease as it ought to. I thank you all for a very, very patient hearing. I've shared my experiences. I've shared what is available in literature, and I shall be happy to take questions from you, either in written or in person, if I can add to your knowledge and could help in some way spreading the message of awareness in treating such very, very unhappy elderly patients. Thank you very much for a patient hearing.
Our first question from Siddharth. Can somebody get osteoporosis genetically as well?
That's a very interesting question. I love the question. We all would get osteoporosis sooner or later in life if we live long enough. Ladies more than men. And genetically, yes, we've all got it from Adam and Eve. So if we live long enough, we shall get it. However, if a person's mother has had severe osteoporosis and has had a fragility fracture, the ladies in that family do have a higher percentage of getting it at an earlier age and getting the sequelae of osteoporosis more than others.
From Preeti. Does caffeine rob the body of calcium? If so, how much is harmful?
I love the question, does caffeine rob the body of calcium? Well, if you go through what comes out in the newspapers, there are times when people speak for and people speak against. But yes, anything beyond the levels of moderation, whether it is consuming coffee, consuming aerated drinks, having too much of tea, all these would hamper the normal metabolism of the system. And doing things within moderation would not. So if it is 1 or 2 cups of coffee a day, fine. But if you're going to be having that mug with you and walking in and out of your workplace, refilling it with that strong coffee, it would keep you awake, but surely at some stage it is doing harm. How much? Well, I have no figures to quote you as to how much of coffee would do you harm, but yes, it would in the long run, so be careful.
Next question from Swaroop Pal. Can pedicle shortening, osteotomy, be used for affection of more than one vertebrae, or is it for a localized disease only at one level?
Thank you, Dr. Sarupal. It's an interesting question. A pedicle subtraction osteotomy, or a shortening procedure, is actually an extension of what is done for deformity correction to osteoporosis, to tuberculosis of the spine, and at times to fracture spine. Can it be done at more than one level? Well, if the deformity is localized and involves more than one contiguous level, let us say that D11 and D12 are both osteoporotic, fractured, and adding to the kyphosis, it could be done at the two contiguous levels for sure. However, if there is a fracture at D8, there's yet another fracture at D11, Then the one which is causing the kyphosis, that could be foreshortened, and it is very unlikely that both D8 and D11 would be having severe angular kyphosis.
From Bhumika, what tips can be given to symptomatic patients of osteoporosis to prevent severe osteoporosis?
Well, that's an excellent question. What tips should we give to people who have osteopenia or osteoporosis to prevent severe osteoporosis? One, all patients who have either attained menopause, and I talk of ladies, or men who have a higher possibility of getting osteoporosis because they may be on anti-seizure medication or taking steroids for other reasons, or maybe having other cause, that means they are at high risk of osteoporosis. All these people, one, should check their vitamin D3 calcium levels, should do it let's say once every 6 months to a year, and maintain it at a good level. Should take an adequate calcium both in diet and with supplements if dietary is inadequate. This would be measured or titrated based on your calcium vitamin D3 levels. Have adequate exposure to sunlight. Take good dairy products. Keep your body weight under control. Do a regular set of exercises to keep your muscles and body well toned. With this, if you've established osteopenia or osteoporosis, do a bone density DEXA BMD once in 2 years. Having said that, only people who have symptomatic sequelae of osteoporosis should look at aggressive medical management for the same. As I look at it, I use bisphosphonates as my primary line of treatment because it is something which I can continue either orally weekly or orally monthly or injectable yearly for 3 to 5 years, depending on how severe the osteoporosis is. Then give a treatment holiday for a year and restart it for 3 to 5 years. However, if I have a patient who's treatment naive and comes with severe osteoporosis, I would counsel them directly to look at teriparatide or the anabolic option, which is a daily injectable dose. So it is quality of life, diet, and medication, all three.
Next question from Devika Sharma. What are drug-free natural alternative treatments for osteoporosis, if any?
Drug-free alternate treatments for osteoporosis, if any. I personally am not aware of these. I would be happy to know of these. I have mentioned alteration and modification of your lifestyle, reducing all the things which do harm to you. But if there is anything else, and if Devika ji knows of it, she can share it with me and I would be happy to be educated.
Second question from Devika. How frequently should I have a bone density test?
Devika ji, I do not know you personally, but if you are in the post-menopausal age, you need to do a DEXA BMD once in 2 years. If you are diagnosed to be osteoporotic, then the 2-yearly follow-up should be done with medication. If you are premenopausal, and this is something which I would request a lot of ladies to hear, please do not unnecessarily subject yourself to a DEXA BMD. You would be surprised with certain reports you may get even at the age of 25 or 27, and then you would be running from orthopedic surgeon to endocrinologist to family physician to rheumatologist and back to orthopedic surgeon till you attain menopause. Very rarely do you have primary osteoporosis, which would be picked up by a qualified person like an endocrinologist, who would then ask you for a DEXA. So it's my humble request to you, Devika ji, if you're premenopausal, do not get a DEXA scan done. Unnecessarily, you'll be carrying the monkey on your back for the rest of your life.
Question from Saraswata Das. Are nutritional supplements like Ensure, Women's Horlicks, etc. help in preventing osteoporosis in elderly?
I love that. All I can say is I have told you that you need a good amount of calcium, a good amount of vitamin D3, a good amount of exposure to sunlight, dairy products, quality of life. Now, if these branded products do contain these, please go ahead and use them. I have no objection to that. But would I be recommending this as a routine to my patients? Well, I don't stop them from taking it, but I'm not the one who's writing the prescription.
Next question from Mukund. How you choose particular biphosphonate therapy, weekly, monthly, or yearly, in your routine practice?
Thank you so much. I appreciate the question, Vipulji. Bisphosphonates in a weekly dose could be either alendronate or risedronate. Bisphosphonate in a monthly dose is ebandronate. Bisphosphonate in a yearly dose is zoledronic acid once a year. Truthfully, if you read all the information available, there is not much to choose between the efficacy of one over the other. You need to sit and counsel your patient. There are certain patients who are happy popping a pill once a week, early in the morning, on an empty stomach with a glass of water, not sleeping or eating for half an hour to 45 minutes thereafter. They are extremely happy doing this every Sunday morning. Fine, give them the weekly dose of the bisphosphonate. There are others who are happy doing it once a month, but not every week. Give them the once a month dose. There are still others who say, Doc, I'm already taking too many pills. Is there something else? Can I take this injection once in a year? Sure, you can give them the injection once in a year. It's an injection which is to be given preferably under medical supervision as an IV parenteral drip over 45 minutes, and you need to observe the patient for the next 3 to 5 hours for high-grade fever and if there is any gastritis. The first such injection usually should be done in a hospital surrounding if possible. Hence, what do? If we have people who are ambulatory coming to us on a regular basis, we offer them the weekly dose. If you have a patient who's actually had a fracture and has been the first diagnosis of the fragility fracture, within a few days of having treated the fracture, we could counsel them in taking that once a year injection such that they would then need to follow up a year later and take the next injection. There are also certain people who are happier taking that once a year injection and forgetting about it. It happens very often. Parents have their children visiting them from overseas once a year. These children bring their elderly parents to us. We give them that yearly injection, and when they come again the following year, they bring the parent again. So it's a counseling issue. Apples to oranges, they work almost the same as far as all the bisphosphonates are concerned.
Next question from Mukund. If the patient is taking letrozole, an oral non-steroidal aromatase inhibitor for the treatment of hormonally responsive breast cancer after surgery, what precaution she should take to prevent osteoporosis?
I love the question. The orthopedic or the spine surgeon is often the first contact for osteoporosis. But in situations like this, we need the medical oncologist and the endocrinologist to help us take the call. One, which medicine would be safe and which would be unsafe. When there is a renal challenge, both bisphosphonates and teriparatide are relatively unsafe. When there is no renal challenge, but the serum parathormone PTH is raised, then we cannot use teriparatide. It's a call that is to be taken as a team. The medical oncologist, the endocrinologist, and the treating orthopedic or spine surgeon would decide what is safe for the patient.
Next question from Swaroop Pal. Is there any specific changes advocated while resting post-spine surgery or after any spine ailment like say sleeping on a hard surface, avoid bending, etc.?
This is with relation to a patient who's undergone a spine surgery and also has his osteoporosis? Well, if it is so, then what I would say is that there is no specific change in lifestyle or quality of life that is recommended. But yes, we do give support to all these patients with braces. We improve their dietary sort of requirements for calcium, vitamin D3, and if necessary, start them on anti-osteoporotic treatment, whether it is bisphosphonates or teriparatide. But things like using a hard bed, soft bed, well, these don't make much of a difference as far as such patients are concerned.
Next question from Kishore Roy. Will calcium in the supplements get deposited in the arteries instead of getting into the bones? How would one know? We hear about this danger.
I also hear about this danger. I also read about it in the newspaper. I also talk to my colleagues who are cardiologists and who are doing procedures to sort out these problems. There is always a small risk of things going against you with whichever medication you may use. However, please try and understand, we have to walk and create a balance. Any medicine we use, whether it's calcium, whether it's bisphosphonate, whether it is teriparatide, whether it is too much of vitamin D3, all done in those high risk situations may backfire. There are people who say we don't take calcium because we've got urinary calculi or stones passing in the urine. Well, we need to discuss it with that patient's treating urologist or nephrologist and then decide which would be the best calcium or vitamin D3 for that patient. Similarly, if somebody is challenged coronary cardiac wise, there is no harm in picking up the phone and talking to the cardiologist, looking at how severely compromised that particular person is. We always need to share and then treat the patient. So I strongly believe that we should work looking at the patient and be patient-centric rather than say that I shall treat only his osteoporosis, he would look only after the arteries, and so will look after the uterus. No, we need to work together as a team. I am just one of those small rungs in the ladder which a person needs to climb as they fight against osteoporosis.
Next question. This question is from Shipra. I have heard of hormone replacement therapy. How effective is this in the treatment for osteoporosis?
Hormone replacement therapy or HRT is an excellent modality of treatment which is used by the gynecologists not used by the orthopedic and the spine surgeon, should not be used by the orthopedic and the spine surgeon. HRT is extremely good. I do know of patients who have been started on HRT and who have been monitored and looked after by the orthopedicians who have also support of the gynecologist and the endocrinologist. There is that slight fear of unmasking a malignancy. But then, as I said, you have to walk the balance. HRT is good, has its place. SERMs or raloxifene is good, has its place. Bisphosphonates have their place. Teriparatide has its place. So each one is there. It's a big basket. And if we live old enough, we may probably need to use all these between menopause and when we turn 100.
Next question from Shailesh. If osteoporosis is detected during pregnancy, would there be any risk involved in the context of treatment involved?
I find it very interesting as to how would somebody diagnose osteoporosis during pregnancy. Anyway, I don't wish to know how. That means a DEXA was done on a premenopausal lady for whatever reasons. But yes, if you do have primary osteoporosis, then that primary cause for the osteoporosis would need to be treated between the gynecologist obstetrician and the endocrinologist. And yes, a lot of drugs would not be recommended, especially in the first trimester of pregnancy. But it's a very rare combination that we are talking of. And I don't think they would reach me as a spine specialist. So it is something where the obstetrician needs to discuss with the endocrinologist and probably work out a plan if such a thing happens.
Next question. Can an infant be diagnosed with an osteopenia?
I love these things. I mean, these are things which are so difficult. Yes. Can I jump off the 14th floor of a building? Yes, I can. But should I jump off the 14th floor of a building? Probably not. So at the end of it all, if we are going to do these tests which are available at a time when they are not necessarily indicated, we'll come up with figures which are surprising to us. Hence, it's very, very difficult to treat these situations. But yes, can there be a patient who is an infant, has bones which break or accidentally break all the time, like osteogenesis imperfecta or some other hormonal issue, or a congenital problem since birth, and could have osteoporosis or osteopenia as a part of the problem? Yes, if it is there, it is there. But there the treatment would be something which the pediatrician, the pediatric endocrinologist would work towards trying to correct. We as orthopedic or spine specialists would come in just to treat the bones, keep them in a position which, if they repeatedly break, that they remain in acceptable situations till a time where the infant grows much older, and maybe we need to do something for deformities or repeated fractures.
Next question from Paul. If I don't consume enough calcium in my daily food intake, is consuming calcium-enriched products is better than taking calcium supplements?
Calcium enriched products better than taking calcium supplements if I don't consume enough calcium? Now, this is a very, very heavily loaded question. One, yes, either you're lactose intolerant, you're one of those who does not like the sight or the taste of milk or anything which is dairy based, perfectly fine. Look at other options of taking calcium and vitamin D3 in your diet. Choosing between supplement and enriched products, to me these look pretty similar, but if there is a difference, well, whatever it is, take one of those at least, unless you're going to ask for trouble.
Next question from Devika Sharma. Do women after hysterectomies need to be more wary of encountering osteoporosis?
Devika ji, lovely question. Do women after hysterectomy need to be more aware and wary of osteoporosis? Hysterectomy is removal of the uterus, and at times the uterus is also removed with oophorectomy. That means the ovaries may also be removed. In which case, the impending osteoporosis in the lady would be expedited. At times, a hysterectomy may be done before your chronological menopause. If you were destined to menopause at 50 years of age, and if for reasons a hysterectomy or an oophorectomy, removal of uterus or removal of the ovaries, was done at 42, 40, some even 35, yes, you have a very high incidence of developing osteoporosis at a much younger age. Be aware, be cautious, discuss with your treating obstetrician. If she or he says to go ahead and visit an endocrinologist for support, please do that and take regular diet, regular supplements, regular exercise. Yes, you are at a higher risk than somebody who had a normal physiological menopause.
Next question from Prerna. She has two questions. First, can exercise or a specific diet help to prevent osteoporosis?
Can exercise and a specific diet help to prevent osteoporosis? Well, osteoporosis is going to happen sooner or later. But yes, exercise and diet enriched with calcium, vitamin D3 would give you the strength to bear and live a good quality life, far superior to lack of exercise, lack of dietary supplements. So it's not going to prevent the inevitable, but it's going to improve your quality of life for sure. Second question from Prerna.
Second question, is strontium a new drug or a new treatment for osteoporosis?
Strontium ranelate has been touted as the next best option which was to come in, has not really made a mark which it was destined to make. There is yet another drug called denosumab which is also being looked at, but today teriparatide has come, it has come and it has stayed. Strontium has knocked the doors but has not entered as aggressively. Denosumab is making inroads but will take some more time. So what do we have today? We have calcium vitamin D3, we have bisphosphonates, and we have teriparatide. And of course, we have the HRT and the SERMs, which are used by my obstetrician gynecology friends.
Question from Saraswata. What precautions should be taken while treating a patient with epilepsy and vitamin D deficiency?
Vitamin D deficiency needs to be corrected. There are various ways of correcting vitamin D3. I would come to it later. But people with epilepsy, all seizure control medication or most seizure control medication do have a negative effect on bone density. So if you are using drugs, especially the phenobarbs and those other drugs, the incidence of reduction in bone density by long-term use of these medicines, which is what is needed for controlling seizures, has to be looked at, and it has to be measured, and it has to be metered in our treatment. Vitamin D, well, it is the best way of correcting it is taking oral supplements of dairy products, exposing ourselves to adequate sunlight, half an hour every day during the daytime, not just the early morning sunlight, but during midday. That's the time that you need to expose yourself for half an hour to sunlight, and taking dietary supplements and oral supplements if necessary. In our country, when patients have very, very low vitamin D3s, let's say sub 5 or at times unrecordable, less than 3, when the normal is 30 to 100. In those situations, injectable vitamin D3 could also be considered. However, indiscreet use of arachital injections, vitamin D3 injections, should not be recommended. I strongly object to people using multiple doses of vitamin D3, either intramuscular in the 6 lakh or orally, breaking the vial and drinking it. Severe vitamin D deficiency, yes, one single ampule of 6 lakhs could be used. Otherwise, the best way is 60,000 international units to be taken orally, either in the form of cholecalciferol, in the form of tablets, powders, now solutions, 60,000 once a week for 8 weeks, and then the same 60,000 once a month for a year. So 60,000 once a week for 8 weeks orally, and 60,000 once a month for a year. Excellent modality, inexpensive in our country, very easily available, and strongly recommended.